Today's virtual lecture will be given by Dr. Dennis DeBernardis. Dr. DeBernardis is a fellowship-trained, board-certified orthopedic surgeon who specializes in all conditions of the shoulder and elbow. He received his medical degree from Rowan University School of Osteopathic Medicine. He then completed his residency training in orthopedic surgery at Jefferson Health of New Jersey, where he served as the chief resident and was charged with overseeing the residency research activity. During medical school and residency training, Dr. DeBernardis scored in the top 10% of the nation on his medical and orthopedic board examinations. During residency, he completed fellowship training in shoulder and elbow surgery at the Cincinnati Shoulder and Elbow Fellowship, where he studied with experts in the field, performing over 900 complex and fundamental shoulder and elbow surgeries. His clinical interests include shoulder and elbow replacement, fracture care, minimally invasive arthroscopic surgeries of the shoulder and elbow. He has particular interest in treatment of sports-related injuries of the upper extremities in throwing athletes. Dr. DeBernardis is actively involved in orthopedic research and furthering the field of shoulder and elbow surgery. He has authored numerous peer-reviewed publications in major orthopedic journals and has been the recipient of several grants allowing him to present his research at National Orthopedic Society meetings. So, Dr. DeBernardis sees patients at our Manhattan office, which is located at 645 Madison Avenue, and our Jersey City location at One Journal Square. This evening, Dr. DeBernardis will be discussing the management of elbow pain. If you have any questions throughout the lecture, you can type them in the Q&A section at the bottom of your screen, and Dr. DeBernardis will answer them at the end of the presentation. And with that, I turn it over to you, Dr. DeBernardis.
Thank you, John. You can hear me, right?
Yep, absolutely.
Good. Good. Thank you. Thank you for the kind introduction. I love the introductions to these talks because they're so complimentary. You would think my mother wrote them. So I appreciate it. Thank you for the introduction, and hello, everyone. I can't see you, but hopefully you can see me. I want to thank you all for attending tonight. I hope this will be a really useful discussion for you. And we were deciding what we should talk about when I gave this lecture to you guys tonight, and I thought the most useful thing we could discuss is the common reasons why we all suffer from elbow pain. This is something that is exceptionally common in the general population. Most of us, if we aren't suffering from chronic or long-term elbow pain now, probably will at some point because of what we do. And this is something that affects almost all of us, whether you work at a very manually intensive labor job, like you work on a construction site or do carpentry, whether you're taking care of your children and raising your kids, whether you're just trying to play your favorite recreational sport. There's a number of common reasons why elbow pain affects us all. And so the goal of this talk is to really cover some of these most common causes and talk about how we identify them and how we treat them, or even how we prevent them. So you can be able to, in a way, even diagnose yourself or know what you can expect when you come and see a doctor such as myself or anyone else who handles shoulder pain. So I'll go ahead and get started with the talk. So to best understand why your elbow is hurting you, I think it's important to understand what is the elbow. It's not just this bend in our arm, but it's actually made up of a number of bones. So we describe the elbow as what we call a complex hinge joint. Just like a hinge on your door, its primary job is to what we call flex and extend the arm, or bend and straighten it. There's a reason the elbow is placed right in the center of our arm. Imagine if we only had our shoulder and our wrist and everything was just one long bone in between, you'd have this straight arm. You wouldn't be able to actually reach your mouth with your hand. So you can't do things like feed yourself, give yourself water, do your hair and wash your face, reach behind your back to clean yourself, to put something in your pocket. So our elbow's job really is to position our hand in space so that it can do its job. And the elbow is made up of 3 bones. It's made up of the upper arm bone that a lot of you may be familiar with, called the humerus. It's also made up of 2 bones in the forearm. This round bone on the outside, if you could see my mouse, called the radius, and this other bone called the ulna that actually makes the hard tip of your elbow that you can feel if you press your elbow, like what you lean on when you lean forward on your desk. And so there's actually 3 bones that make up the elbow, not just 2. It's where these 3 bones meet or intersect that creates the elbow joint. And so I already mentioned that primary job is flexion and extension. So bending the arm and straightening the arm to bring the hand closer to your face or further away. But it has another job. So that round bone on the outside, we call the radius, it's shaped kind of like a wheel. And when that wheel turns, it rotates the palm up and rotates the palm down. So we usually think of that rotation, which we call pronation and supination, as coming from the wrist. So to turn our palm up toward the ceiling or down toward the ground, like to give a high five, we think that occurs at the wrist. It actually occurs at this other joint in the elbow that we call the radiocapitellar joint. So the elbow lets us turn our palm up and down and also lets us bend and straighten the arm. And so in addition, there's a number of muscles that cross or live near the elbow joint. It's important to know where these live or where they exist because they are common causes for pain. And so the ones we're probably most familiar with are the biceps and the triceps. And so the biceps muscle is the big beefy muscle in the front of the arm. We're familiar with it. It's the glory muscle. It's the glitter muscle. And so its job when it flexes or contracts is to bend the elbow and bring our hand closer to our face. Whereas the triceps is the larger muscle on the back of the arm. And when it contracts or shortens, it attaches to the back of the arm and helps us straighten the elbow to push things away from us, do a push-up, push ourselves up from bed. But the other muscles that live near the elbow are what we call the wrist and finger flexors and extensors. So the extensors live on the back of the forearm. They help us straighten our elbow and straighten our fingers, and they attach on the outside of the elbow. And the wrist flexors and the finger flexors help us bend our wrist and curl our fingers in to make a fist. They live on the inside of the elbow. That's where they attach near the elbow. So there's a lot of muscles, not just the biceps and triceps, but a number of other muscles in the forearm that live near the elbow too, and they could be a common source of pain. And so there's about 1 million reasons, whether it's an injury or common reasons why we get pain in our elbow. So for the purpose of this talk, I wanted to group them into 3 of the most common causes. And so the first being tendonitis, which is usually an overuse or inflammation sort of pain in the elbow. And any tendon that lives near the elbow can become inflamed and get tendonitic, we call it, or have tendonitis. But by far the most common are the 2 that most people in this crowd today probably are familiar with, which is tennis elbow and golfer's elbow. And we'll dig a little deeper into that in a few upcoming slides. Sometimes tears don't just get, or tendons don't just get inflamed from use, but if you have what we call an acute injury, which is more of a traumatic or new onset pain from something like a fall or lifting something and feeling a pop, these tendons don't just get inflamed, they can actually tear. And most commonly, or the ones that we're most concerned about in the elbow, are tears of the biceps and the triceps tendon. And finally, we talked a lot about tendons, but the bones themselves can get injured. So whether that's a contusion, which is kind of like a bone bruise, you bump your elbow and it gets bruised, kind of like your skin, or a fracture, which is the same as a break, depending on how hard you hit the bone or the position of your hand when you're doing that. And so these are the 3 categories we'll cover today. And so every problem is diagnosed in a different way and requires different tests. But in general, when you walk into your physician's office, for example, if you came to see me with elbow pain, the first thing that we start with is a comprehensive or thorough physical exam. So things like seeing how you're able to move your elbow, that's range of motion. Do you have full flexion and extension? Are you stiff and you can't move your elbow very well? That gives us a lot of information about what's going on and the major cause of your pain. Testing your strength to see, are the muscles and tendons working? If there's tears or tendonitis, you may have less strength because of pain. You may just have weakness. There's a number of reasons why your strength can be affected. And tenderness. So where is your pain? Sometimes the pain is pinpoints exactly in one location, and it might hurt when we press on it. And that gives us a lot of good information to help diagnose your problem. In general, when you have a new problem or a new pain, we start with an X-ray at your first visit. It's important because even if you have a soft tissue problem, getting an X-ray can show us that the bone is normal. And knowing that the bone is normal helps us rule out a lot of common causes for elbow pain and tells us maybe it's actually more of a soft tissue problem. And so most patients think, why do I need an X-ray? Well, it's because soft tissue injuries and bone injuries can present similarly. And so knowing that it's not coming from the bone or it is helps guide our path as far as deciding what the problem is for your elbow. If your doctor wants to take a deeper look into your elbow, he or she might order an MRI that helps us get a more detailed look at the soft tissues around the elbow, or an ultrasound, which is even a quicker or less invasive or really cheaper way to look at the soft tissues around the elbow, but sometimes less detailed. And that's why we typically go the route of the MRI. If you may have a subtle or discrete injury to the bone, then we may consider getting a CAT scan. It's like a 3-dimensional view of your bone and gives us a lot of sharp and fine detail about what's going on with the elbow. And so your doctor may order that if there's a concern for damage or fracture of the bone. And finally, an EMG is a nerve test. Sometimes pain around our elbow or forearm can actually be because of a compressed nerve, whether the nerve is pinched in your neck or pinched in the arm somewhere. And an EMG is a nerve test that allows you to determine, is a nerve being pinched? If so, which nerve is being compressed and exactly where? Is it up in the neck? Is it down in the arm? Is it at the wrist? And so this is a detailed way to determine that information. This is a general treatment guideline. So again, every issue is specific as far as how it's treated, but this is a general pathway we tend to follow. So in what we call chronic injuries or chronic pain, which is kind of older or more long-standing pain, something that's been around for a few weeks, few months, even a few years, usually it's not due to a single injury. It's something that sort of creeps up over time. And that, if that's the case, we tend to stay more to the left side of this diagram. So you may have heard of the RICE technique, which stands for rest, ice, compression, and elevation. So a lot of these things are from overuse. The more we rest them and give them time to recover, the better your pain is. And so it can be really effective. Ice, compression, and elevation of the arm help decrease swelling, which can help decrease pain. And often physical therapy can be really the mainstay of treatment. It can be the thing that really does the trick to put you over the edge to feel a lot better. And again, I mentioned a lot of this is overuse injury or problems with how we're using the muscle. And if we can make the muscle work more efficiently or strengthen it or even stretch it, that can help decrease a lot of your pain. Usually we'll start with these things, and if they don't work, sometimes a corticosteroid injection, which is just another name for a steroid, is a good option to help decrease your pain, especially quickly. It's a really, really strong or powerful anti-inflammatory medicine. And usually we inject it directly at the site of where your pain is, so it can bathe that area in an anti-inflammatory medicine that can help decrease inflammation to decrease pain and swelling. And in these chronic or long-term injuries, we typically try all of this before we even consider surgery. And so we only move on to surgery if these fail. Now that's as opposed to what we call acute injuries. These are usually newer. They're usually a more severe or sharp pain. They usually happen from a one-time event. So last week I was snowboarding and I fell. Last week I was lifting this heavy object and I felt a pop. So more a sharp or new injury. And sometimes those result in more severe injuries. And that's usually the only time that we jump straight to surgery. Because sometimes these are injuries where surgery is either the only option to get you back to normal function, or it's the best option out of what we have to really get you going quickly and restore your normal strength and motion that you may have had before your injury. And so to get into some of the more descriptive or some of the more detailed reasons for elbow pain, I'd like to start with tendonitis. So if you separate the word tendonitis into its two parts, tendon and itis, gives you a good idea of what that means. And so tendon is the soft tissue attachment that connects muscle to bone. Muscle is like a motor in your car. If it doesn't have the wheels, it can fire all at once. It doesn't move anything. Tendon is kind of like the wheels. It lets the motor, which is the muscle, attached to the bone to pull it, to move it in space. And itis, if you hear itis on the end of any word, it means disease of inflammation. So think about any word you know that means that has itis afterward. For example, tendonitis, inflammation of a tendon. Colitis, inflammation of your colon. Arthritis, inflammation of your joints. So that's really what that means. And that's what this problem is. It's a disease or a problem of inflammation, whether it's from overuse, or sometimes what we call idiopathic, which means it just happens and you're predisposed for whatever reason. And any of the tendons about the elbow can be exposed to tendonitis. But as I mentioned before, most commonly, we see tennis and golfer's elbow. This is incredibly common, and I probably see 5 to 6 patients in my office every single day with this exact problem. So tennis elbow happens on the outside of the elbow. It's where the wrist and finger extensor is attached, whereas golfer's elbow is on the inside of the elbow, where the wrist and finger flexors. So a lot more to do with grip and squeezing with your hand. Usually it's very straightforward. It causes pain exactly at the attachment site of these tendons. So usually patients will come into my office and point exactly to the outer elbow or exactly to the inner elbow and say, this is exactly where it hurts. Anytime I do these activities, it bothers me right here. And usually the pain doesn't really radiate. It's localized exactly in that location. Every once in a while, it can travel about maybe a third or halfway down the forearm, but it's usually at the outer or inner elbow at around the site of the bone where the tendon attaches. Now, many people come into my office and say, I'm kind of like Adam Sandler in most of his movies. I don't actually play any of these sports. So I don't play tennis. I don't play golf. Why would any of this bother me? Well, this is how it was originally described, tennis and golfer's elbow. A lot of tennis and golfer's elbow sustain this. A lot of tennis and golfers sustain these injuries. And we know it does have to do with how you're playing the sport, how well you're playing, and your equipment. So for example, tennis, it usually has to do with your backhand. And we know that your equipment can affect this too. So if your racket is too heavy, if your grip size is too large or too small for your hand, if the tension on your racket's improper, if it's too taut or too high tension, it sends extra force to your elbow that can cause pain. And same with repetitive golf swings. But I would say most of the patients that come to my office with this problem don't actually play tennis or golf. They do other activities that are more repetitive that actually cause their pain. So think about any repetitive gripping, twisting, lifting activities. So a lot of us, our job involves mostly computer work. Resting your wrist on the desk and hyperextending the wrist all day long to type is really bad for the tendons on the outside of the elbow that help you lift your wrist up. repetitive work like opening jars, like people who work in labor-intensive jobs and use tools. So gripping and twisting of a hammer, of a screwdriver. These are all things that when done over and over again every single day, eventually it generates a lot of inflammation at the site of the tendon where they attach to the elbow. And so these are all reasons why you can get tennis or golfer's elbow. The diagnosis is usually very straightforward. We often get x-rays to make sure that it's not something like arthritis of the elbow on the outer part of the elbow or evidence of an old break, but usually the physical exam is all you really need. So when your doctor comes in, they'll press exactly on the tendon that usually is the culprit, and it causes a ton of pain. We may ask you to do some of these activities that we know can generate this pain. So against resistance, try and turn your palm up toward the ceiling or down toward the ground. Try and lift your wrist back like you're revving a motorcycle, or bend it down toward the ground. And with resistance, it can be really painful. And doing things like gripping and twisting activities that will recreate your pain usually gives this away. An MRI is not usually needed to diagnose this problem. Usually just an x-ray and your physical exam. But oftentimes after we tried a lot of treatments, if it's not getting better, I'll order an MRI to take a look at the integrity of the tendon. It can help us tell a difference between, is the tendon normal in appearance, just a little inflamed, or when the tendon experiences inflammation for a really long time, it can actually change the quality of the tendon, which you can tell on the MRI. Sometimes you get partial tearing. Sometimes the tendon, so tendons in general are like really thick rope-like structures that are really strong. When they're inflamed for a long time, they change in appearance. They become softer and mushier. They're less robust. And you can tell that on an x-ray that the quality actually changes, or I'm sorry, on an MRI. And so in general, we always start with non-operative treatment because this is one of those more chronic injuries I described. And the good news about tennis elbow is that about 90 to 95% of people experience successful treatment and relief of their pain without surgery. The difficult thing about tennis elbow and golfer's elbow is that it's a very tedious problem to treat and typically lasts for a while. So even though 90 to 95% of people never need surgery, it could take 6 months, even greater than a year, for your pain to actually completely resolve. So it definitely requires a lot of patience. We start with the Rice technique like we talked about and trying to avoid any gripping, twisting activities. We usually recommend you use the other hand or the other arm to do things like using your screwdriver and your tools, opening a jar. The problem is that it's not uncommon to see this in both elbows. And then you really have to decide how you're going to compensate or how you're going to change your activities. We may offer bracing. So even though the pain is at the elbow, it's actually motion of the wrist against resistance that causes this pain. So braces like in the bottom right can hold the wrist still for some time and allow these muscles to rest and recuperate to make the pain go away. The top left is what we call a counterforce strap or brace. This applies slight compression of the forearm muscles that are inflamed to help decrease pain and inflammation, and it changes the location of the force when you're using the forearm muscles to help take some force and some stress off the tendons at the elbow and place them elsewhere, because usually it makes activity a little bit more tolerable. We often recommend medication because this is a problem of inflammation. So using an anti-inflammatory medication can be really, really effective at decreasing inflammation and decreasing pain. So common over-the-counter medicines that can be really effective are things like Tylenol, ibuprofen, and naproxen, which are things like Advil and Aleve. And we will almost always recommend you use these because they can be really effective at decreasing your pain. And finally, physical therapy or home exercises. So this is an abnormality in the muscle and the tendon unit at your elbow that helps you bend your wrist up and down and rotate your palm. So if we can stretch and alleviate the pain of the elbow, and we can strengthen these muscles and the other muscles that do a similar job, we can help alleviate some of the stress that these tendons are seeing and help them work more efficiently, become stronger to help you function with less pain. This is typically what I start with, and I give patients a few months to give this a shot. Because like I mentioned, this is not a one and done treatment. This is a patience and time issue. And so if after a few months this isn't working, that's when I'll consider offering patients an injection. And there's two major types of injections that we offer to patients when they have this problem. And the first is a steroid. I mentioned before, it's a really strong anti-inflammatory medication that we inject directly over the inflamed tendon in hopes of decreasing your pain. And usually it's very, very effective. The problem I've seen with steroid is that the effects can be pretty short-lived. So it may cause really rapid relief of your pain. Within a few days, you're feeling a lot better, but it's not uncommon for that pain to come back after only a month or a few months. And so we prefer to not keep injecting and injecting and injecting, because steroid once, twice is not bad for the tendon, but repeatedly injecting steroid can weaken the tendon. And so if one, maybe two of these injections don't work, another really excellent treatment option is what's called PRP, you may have heard of. It stands for platelet-rich plasma. And so it's a way of us sort of hijacking your body's own immune and health system and blood cells to direct your body's own healing potential directly at the site of lateral epicondylitis or tennis elbow, the site where the tendon is inflamed. And so it involves taking a small sample of your blood, just like if you were to get a blood test, putting in a tube and spinning this tube in a machine to separate your blood into its different components. The fluid goes to the top and the red blood cells go to the bottom. And somewhere in the middle is a layer of cells that are called platelets. And these are blood cells that specifically are able to emit healing factors. And we take this concentrated fluid containing only your platelets and we inject your body's own blood cells back into your elbow directly at the site of inflammation. And it's been shown to be really effective at promoting some long-term pain relief, whereas the steroid tends to be a little bit more short-term. I mentioned surgery is very rarely required for this problem. And so maybe only 5 to 10% of patients actually ever fail all these other options that I mentioned, which are pretty exhaustive in nature. And so the surgery involves a small incision on the outside of the elbow where we look at the partially torn or diseased tendon and we remove any of the unhealthy tendon, leaving only healthy tendon behind, and give you a short time to let this tendon heal and then start moving your elbow pretty quickly. And often as a last resort, it can be pretty helpful at decreasing your pain. But of course, we also recommend lifestyle changes where we say the things that were causing this in the first place, it can absolutely come back if we remove the diseased tendon. And so we recommend changing things at work or at home that may be inciting this pain. And so maybe your tendons are not just inflamed, but you may have an accident where you experience tearing of a tendon. And I mentioned before, it's most common in the biceps and triceps. So the biceps that attaches to the front of the forearm and helps you flex your elbow, and the triceps that attaches to the back of the elbow. And right, and they're located where you can see here on the left side. And so these are by far more common in men, especially young men, usually having to do with how we decide to spend our time, either recreationally, with exercise, or jobs that men choose to do. But that's not to say this is only seen in large, young weightlifters who are lifting more than they probably should. This is actually probably more common in your everyday weekend warrior who's just trying to get back into the gym and exercise and get in shape and lift weights. And maybe they're deconditioned and they haven't been doing that. Or in young to middle-aged men who at work or at home are lifting something a little too heavy and suddenly feel a sharp pain or sharp pop. And you can see on the right that the tendon will actually tear from its insertion on the bone. And so when we diagnose these issues, usually it's pretty clear. Patients often will come in and say, I heard or felt a pop when I was lifting something or I was pushing something away. And the arm will look kind of like you see in these two pictures. So on the left is a gentleman with a biceps tear where you can see that he has a lot of bruising around the elbow. That's the site where the tendon usually lives and where it tears from. And tendons get a lot of blood flow. And so when they tear, they result in bleeding. And that's what a bruise is, bleeding under the skin. And on the right, someone with a triceps tear has a lot of bleeding at the back of the elbow toward where the triceps inserts. Now, the biceps, you can see it looks funny. It looks like it's rolled up the arm. And so our muscles are attached at the top and bottom of the arm. And so if you detach it from the bottom, it rolls up the arm, kind of like a window shade. If you pull it down and it flings up the arm, and it creates this bunched up ball appearance of the bicep that we say looks kind of like Popeye the Sailor Man, who has this big bulky muscle. And so we call it a Popeye deformity. That's actually where it gets its name. The other way to diagnose this is even right now, if sitting at home, you try and bend your elbow and you use your other hand, you take your finger and you create the shape of a hook and try and hook inside the crux or the bend of your elbow. You can feel your biceps tendon, assuming none of you have biceps tears. You can actually hook around it. It's this thick rope-like structure. If you try that at home, you should be able to feel it. And obviously, if there's a tear and the tendon's no longer present in the elbow, when you come into my office, we'll do this, what's called the hook test, and we'll try and see if we can feel it. And usually it's absent or not present in the elbow. So even though it can be pretty obvious, an MRI can be really helpful to, one, confirm that the tendon's torn, and two, to show us exactly where the tendon is. I mentioned that when the tendon tears, sometimes the muscle can slide up the arm. And if it has slid very far up the arm, it can be difficult to find in the event surgery is needed. And so knowing how much of the tendon is left, where the tendon is located in the arm, can be really helpful in the event that we have to plan for surgery. And so on the left, you can see highlighted is the end of the tendon and the bone onto which it typically attaches. And the black arrow between shows the amount of space, showing that there's empty space and that it's not actually attached. On the right, you can see the highlighted biceps tendon that's sort of squiggly in nature because it's like a rubber band that's been tensioned and then allowed to let go, so it sort of recoils up the arm. And you can see the forearm bone where it's supposed to attach, and it's pretty far away in this photo. And so in general, biceps tears, we almost always recommend getting surgery, unless you're too sick to undergo surgery or there's another reason why surgery is not a great option for you. We usually recommend, because imagine if the biceps is torn, you lose the function that the biceps usually gives you. And so when you tear the biceps isn't responsible just for bending the elbow, but also for that supination motion I mentioned. So it gives you strength in rotating your palm up to do things like if you work with tools in your job or have to open things at home, like opening jars and cans, you lose some of that strength. So you lose about 40% of your strength in twisting and about 30% of strength in elbow flexion. So think about lifting, bending your elbow to lift weights, to lift grocery bags. You lose a portion of that strength. And 30 and 40% is a lot. That's almost half. And so without that, it really compromises your elbow function, not just in exercise, but even in day-to-day life. Now, what happens if you don't do surgery? Well, this is not something that's going to affect your lifespan, right? So there's not many things in orthopedics where you absolutely have to have surgery. But though it may not affect your lifespan, it will affect your quality of life. And so without that function, it'll be difficult to do some of the things you love. But notice I said you don't lose 100% of the strength in rotation or 100% of your strength in elbow flexion. You only lose a large portion because there's actually other muscles that do a similar job. So in the bottom, you can see there's a muscle underneath the biceps called the brachialis that helps the biceps flex your elbow. On the right, you can see a smaller muscle. We call it the supinator. It's another muscle that helps you rotate your palm up. So that's why you don't lose 100% of strength. You just lose a large portion of it because there's other muscles that can do something similar to the biceps. So you'll still be able to do these actions just with much less strength and power. Now, in contrast, that's in contrast to the triceps. So if you look at the back of the arm, there's only two major muscles that can help you extend the elbow. There's the really large and beefy triceps muscle and the really tiny muscle we call the anconeus. That's like saying, who would you rather have help you to straighten your elbow against resistance, the man on the left or the wimpy guy on the right? And so imagine if you lose the triceps, you lose the big, strong motor on the back of the arm that helps you push things away, push yourself up, straighten the elbow, and you only have the really small anconeus left to help do that. And so you lose the majority, not just 30 or 40%, but the majority of your strength in elbow extension. And that's why for triceps tears, we, again, almost always recommend that these are treated surgically, because if they're not repaired and you lose the function of the triceps, the goal is not to just restore your ability to do exercise like push-ups and chest press and shoulder press, which you obviously need your triceps for. But even think about simple functions that require you to push away from your body, like getting yourself up from a chair. Like if you fall on the ground, stay getting yourself up off the floor. So without this, even simple functions like standing up from a seated position become really, really difficult. And so fixing these usually requires a surgery, of course, and we actually repair your own tendon. So a biceps or a triceps repair are repaired somewhat similarly. They're carried out somewhat similarly, in that the technique usually involves a small incision to look at the torn end of the tendon. We use what we call non-absorbable suture, which is like very, very strong thread that we sew through the tendon, and we reattach to bone using any number of techniques, either absorbable bone screws or metal buttons. But however we choose to do it, it involves reattaching the tendon back to bone. And the surgery is not even often the hard part. It's actually the recovery that can be pretty difficult. And that's because it takes a while for tendon to heal back to bone, a pretty long time. And so for the first 6 weeks, we usually ask you to not move the elbow at all and put you in a splint, or we allow very, very little movement of the elbow. And that's because though those sutures I mentioned are very, very strong, even you with your torn tendon are stronger. So if you try to move the elbow, you are stronger than those sutures that are holding the tendon in place. It can very easily re-tear. And so at about 6 weeks, the tendon is still not healed. However, it's sticky enough in a way to the bone that we could start gently moving your elbow, but not with any resistance. So we can't, no pushing and no pulling against any resistance or with any weight, just motion in the elbow. That's at about a month and a half after surgery. At 3 months after surgery, enough healing has occurred that we could start gentle strengthening, usually 5 to 6 pounds or 5 to 10 pounds as far as a weight limit restriction. And the goal is getting you back to whatever sport or activity you like doing, or no restrictions, essentially, by 5 or 6 months, usually the earliest. So I usually have patients on a weight limit restriction until about 6 months after surgery, when I know the tendon is strong and robust enough, and I know you have all your motion back, before I start saying you can now get back to lifting or doing whatever activity you want without any limitations. So we talked about tendons almost to death, but now we'll move on to bone injuries. So the bone can be injured when you fall, of course, and when you hit the bone, when you strike the bone on the ground or an object, or you fall on an outstretched hand, you can either get what's called a bone contusion, which is essentially a synonym for a bone bruise. It's a lot like I mentioned before, a bruise of the skin. When you bump your knee gets black and blue, and that black and blue area represents blood. So you have a little bit of bleeding under the skin, and that's what causes that color change or discoloration. The same thing can happen in your bone. So your bone actually has a lot of blood flow. And if you strike the bone hard enough on the ground, you can actually get some bleeding within the bone. And so it really is a bruise of the bone that can cause a lot of pain. Sometimes if you strike the bone hard enough, or if you fall with your arm in the right position, you can actually get a break in the bone. So there's an actual crack going through the bone, separating it into at least two different pieces. And a really important thing that we look out for as physicians is to see when the bone breaks, does the bone break and move, like in the right side of the picture, or does the bone break and stay perfectly still? And knowing that can help us decide whether that's something that needs surgery or not. And the last thing to mention is you may hear the term fracture. The bone is broken, the bone is fractured, and I'd let you know that that's actually the exact same thing. So whether it's described as a break or a fracture, either way, the bone is broken. So they're synonyms. And so just like with tendons, any of the bones around the elbow can be injured, but most commonly the bone that makes up the tip of the elbow is injured. So if you look, the ulna is the bone that makes the tip of the elbow, and that tip of the elbow, that pointy process, we actually call the olecranon. And that represents the tip of the elbow. So when you lean forward on your elbow or lean onto a desk chair, that is the portion of the elbow that most commonly gets injured. And it's because, like you can see on this gentleman on the right, or even the x-ray in the middle, it is the least padded portion of our body, kind of like our kneecaps. No matter how large or small you are, no matter how tall or short you are, the tip of our elbow and our kneecaps, we call our patella, never have much meat, not much fat or muscle around them. They're always directly under the skin. Because they're so exposed, they are the bones that are most commonly injured after a fall. And so I mentioned with a contusion, the bone's not actually broken, it's just bruised. So it's important to get x-rays because usually this can be pretty painful. And the x-ray will show us that it's not actually broken. And so the bones will appear normal. And a good way on exam to tell that it's actually just a contusion is that you can actually still bend and straighten the elbow. When bones are broken, sometimes you get very stiff or you lose the ability to move the elbow. And so with a contusion, it will still move. It might be very painful, but it will certainly still move. It's also usually very tender to touch. So whether you or the doctor are palpating the elbow, or if you lean forward onto the elbow on a hard surface, it'll be really, really painful. That's another hint that this is a contusion. You usually don't need an MRI. Just your physical exam and the x-ray showing it's not broken are enough. But if you're concerned, this is one of those what we call occult fractures, which is a break when the bone stays so perfectly still you can't even see it on x-ray, which I'll tell you in this bone specifically is not very common, though it can happen. You can get an MRI. So an MRI will let us look at not just the soft tissues, but more detail will let us look at the bone. And so you can see here on the right, the arrows are pointing to glowing parts of the bone. Bone generally on the MRI is kind of like this dark to medium color gray, and anything that's light in color, light gray or white, represents fluid. And so you can see fluid between the bones. That's normal fluid in your elbow. But when you see a glowing appearance or a bright white inside the bone, that's actually bleeding or fluid inside the bone that happens after a contusion. And so the best way to treat a bone contusion, and the most important factor to treating a bone contusion, is actually time. It takes time for your body to remove the bleeding and the swelling in the bone and bring it back into your bloodstream. And unfortunately, that could take weeks or even months. So this is not something that, if you hit your elbow hard enough and have a contusion, that we expect to be better in a week. It may take quite a while, but you should absolutely notice a difference within the first month. So within the first 4 weeks, I don't expect your pain to be gone, but I would expect that it's improving, going the right direction. And so we usually employ things like the Rice method. So resting the elbow, avoiding any heavy lifting, pushing, or pulling, because the tendons that attach to the elbow could tug on the bone that's injured, and that could re-incite or re-aggravate your pain. Ice can be really helpful at treating pain and swelling of the elbow. But like I mentioned, time is by far the most important thing. You can use anti-inflammatory medications like I talked about before, Tylenol, ibuprofen, naproxen, to help with pain and swelling. And a lot of people will say, hey, do I need to wear a sling for this to rest the arm? Should I be put in a splint, which is kind of like a half of a cast? Is that something I need to rest the arm? And I would say, because it's not broken, it's really important to move the arm, because sometimes patients are coming to my office after they've been put into a sling or a splint, and their arm is resting in that bent position for a while, and they're waiting for this to go away. If you stay in a sling or a splint until this is gone, you'll be in that sling or splint for a month or months. And by the time you come out of it, you'll say, my pain's great, but now your elbow will be so stiff you can't even move. And so sometimes these can do more damage than good. So moving the arm is really crucial to preserving your range of motion. Now, every once in a while, if you hit the elbow hard enough, that tip or that olecranon will actually break, not just get a bruise. And so infrequently, you'll see an x-ray like you do on the left, where there's a crack going through the bone, but the bone hasn't actually shifted. More commonly, you'll see the x-ray like we see on the right, where you can see the two ends of the bone with space in between, so that the tip of that elbow has broken and has been pulled away from the rest of the elbow. So that's what we call a displaced fracture. It's actually shifted away from its normal position. And the reason why that's more common is because, like we mentioned on the right, you can see that really strong triceps muscle attaches to the olecranon, or to the tip of the elbow. So after the elbow breaks, you have that tendon that's pulling on the tip of the elbow and pulls it away from the rest of the bone. And that's why usually we recommend this is fixed. We fix it for a few reasons. When it's pulled away like that, the attachment of the triceps is gone. So even though the triceps is still attached to the bone's not attached to anything. So this functions exactly like a triceps tendon tear. So unless it's fixed, the triceps is pulling on nothing. So you lose that ability to push your elbow or push your arm away from you in space with any strength, lifting yourself up from the ground, doing a push-up, anything like that. The other reason is because our joints are supposed to be perfectly smooth and aligned, like two puzzle pieces that fit perfectly together. They're supposed to be very smooth and contoured. Imagine like driving on a perfectly paved road. Well, when the bones are broken, you can see the joint is disturbed. It's like there's a giant pothole. And you know what driving on a road with potholes does to your tires, it completely wears them out. Same thing happens in a break like this. If you have a break that creates this big divot or hole in the joint, now the joint starts to wear out and you may get arthritis in your elbow. Whereas if it was fixed or never occurred at all, you may have never actually gotten arthritis in your elbow because it's pretty uncommon. So those are the two major reasons why we fix these fractures. In the infrequent event in which this bone breaks and doesn't shift, because like I mentioned, the triceps is tugging on it, we can just observe. So we can splint you to keep the elbow still and take x-rays. My personal algorithm is if you come into my office with this injury that's only a few days old, I have you fob with me once a week for the next 3 weeks to take x-rays, because it's very possible, even if we keep you still in a splint, that the muscle tugs on this bone and actually displaces it or moves it away. And if that's true, if that occurs, then we have to consider surgery. But if not, we can keep you in a splint that looks something like this, kind of like a half cast. And we follow you over the course to make sure that bone doesn't displace. And usually as long as it heals, you can have a pretty good outcome. So to fix these breaks or these fractures, it's a small incision on the back of the elbow, reconnecting those two pieces of bone and holding it there with metal plates and screws. And these plates and screws are really, really strong. So probably the third benefit of doing surgery is that if you have a break and we fix it with these, they're strong enough to hold your elbow together while we start gentle motion. Whereas if the bone doesn't move and we watch you in a splint, you can't move the elbow at all for at least 6 weeks until healing occurs. So if the plate and screws are holding the bone together like we hope they do, then for the first 6 weeks, for the first 2 weeks, maybe we'll keep you still in a splint. And after that, we start some gentle, light motion. We can actually get you going a little bit sooner. Takes usually about 6 weeks to see any healing on x-ray. The bone's not completely healed, but you'll see enough where we feel comfortable progressing your motion. So getting you back to full range of motion after that. And between 6 weeks and 3 months, our first goal is to get you back to normal motion. So making sure you can fully bend and straighten the elbow, rotate your palm up, rotate your palm down. And then eventually, once the bone's completely healed, to strengthen the arm, get you back to your normal strength and function with the elbow so you can go back to the activities you were doing before you fell and broke your arm. Now, I mentioned there's the other bone of the elbow called the radius, that circular bone. And that bone's job is to help you rotate your palm up and down. And so it's usually under a lot of fat and muscle, so it's not as exposed as the olecranon. So it happens for a different reason. A lot of times you may fall from a height and you reach your hand down to break your fall. And when you straighten your elbow and reach your hand down, the force is transmitted up your forearm and into this radius, or what we call the radial head. That's the round portion that makes up the elbow. And so you can see in the x-ray on the center, there's that crack and what we call step off. The joint isn't smooth anymore. And I mentioned it's really important to notice, like with the olecranon and any other break, when the bone breaks, does it move or does it stay still? So when the bone stays perfectly still, usually you don't need surgery. We'll put you in a sling for a couple of weeks and get you moving pretty quickly. But sometimes when the bone breaks, you have one big piece that snaps off, or sometimes it smashes into a number of pieces. We call that comminution. It basically just describes a break. Imagine dropping a mirror on the ground. It can shatter into a number of pieces, and you can imagine how difficult that would be to put back together. So I mentioned when the bone doesn't break, we can put you in a sling for comfort for maybe a week or so, but we actually get you moving pretty quickly so your elbow doesn't get stiff. If one large piece breaks off, then in order to preserve your ability to move your palm up and palm down, which can be inhibited when you have a fracture like this, we will fix the bone. So we'll take that large chunk and put it back where it came from and hold it with plates and screws, just like with when you break the tip of your elbow. I already talked about if you smashed a mirror on the ground, it'd be difficult, almost impossible to put it back together. Same thing with this. If this breaks into too many pieces, it's too difficult to put back together, and you'd have a pretty bad outcome if we try to do that. So instead, we remove the broken pieces and we replace it with an exact replica, basically, of the radial head. So we call it a radial head replacement. It's a piece of metal that inserts in the bone and is shaped the same as your radial head to let you restore that function of turning your palm up and down without pain. And it can be a pretty effective treatment option for this. And so the final special shout out that I didn't really feel fit into any of these categories specifically is bursitis. And this is also exceptionally common. And so bursitis is, you might notice, hey, I'm having some pain over the tip of my elbow and I have this bulbous sort of appearance. And so we all have a bursa on top of the bones that I mentioned are just under the skin. So both your kneecaps and your olecranon, the tip of your elbow. And it's this soft tissue sac that usually does not have any fluid in it, but if it's irritated either because we bumped the elbow or because we're leaning on the elbow and rubbing on the elbow too much, for example, if we work at an office desk and a chair and we're leaning on our elbows too much, or you work as, for example, a plumber, we see this pretty commonly. These are men and women who are on their hands and knees for a long period of time during the day without maybe pads to protect, and the bursa gets really inflamed and it fills up with fluid, and it creates this sort of golf ball sized pouch on the back of your elbow that feels almost like a water balloon, because that's what it is. It's filled with fluid. And so, like I mentioned, this is not just people who work on their hands and knees, but even everyday people who work in an office at a computer are spending too much time leaning forward on their desk. They commonly see this happen too. And so, because it's inflamed and aggravated, anti-inflammatories are a really good treatment option for this. And we'll also recommend a combination of compression and protection of the elbow. So you'll see these sort of neoprene or compressive sleeves that you can slide up over the elbow. When you compress it like that, it can help your body reabsorb some of the fluid and decrease swelling. And they usually have these soft pads on the back. So if you're doing things like leaning forward at your desk or leaning on the floor to fix something or do your job, you're aggravating the elbow a lot less. If these don't work over the course of time, there are options where in the office we can use a small needle to remove the fluid. And usually it's a very clear yellow fluid. It's not very concerning. It's just the normal fluid your body produces when this bursa is inflamed and aggravated. And so we can remove it. The problem is, as long as the bursa is still inflamed, the fluid can commonly come back. And so every once in a while, we'll actually do a small surgery to remove the fluid-filled sac, so there's no space left for the elbow to fill up with fluid. But often we don't have to get that. And it's also a decision to say, sometimes this bursitis doesn't actually hurt. Every once in a while, it's just present and it ends up being more of a cosmetic issue. And so deciding whether or not surgery is worth it for just a cosmetic appearance is a discussion between you and your doctor. But if it's painful, it's absolutely worth considering to do. And so I think a common cliche is in sports is that the best defense is a good offense. I think I had that backwards. The best offense is a good defense. And so the best way to treat any of these issues is actually to prevent them from happening in the first place. And there's a lot of very easy ways you can either modify your home or the activities that you're doing to make sure that you never have to suffer from this pain in the first place. And so, for those of us who may work from home or at a computer, ergonomic modifications of your workplace can be really, really important to preventing these injuries from happening. So I usually will recommend, hey, consider getting a pad to put in front of your keypad, like a soft pad to put in front of your keyboard, I should say, to elevate the wrist. So it's not in this hyperextended position, but it's more straight and neutral to take tension off the extensors of the elbow and of the wrist, or putting pads either on your desk or on your armchair so that your elbows aren't rubbing against a hard surface all day and getting irritated and inflamed. If you notice that you're getting elbow pain and you think it has to do with the sport you play or what you're doing at work or how you're lifting and carrying things, making sure your equipment is appropriate and your technique is appropriate are both really, really important to prevention of injury. So we talked about what causes this in tennis, making sure your tennis racket size, your string tension is all good, making sure your form and your backhand is appropriate. So taking lessons can be really helpful. And even simple things like if you're lifting at home, making sure you're using your legs, not a combination of your back and arms repeatedly, so you're not really damaging and inflaming those tendons. Making sure if you have to lift something heavy, you're doing it with a buddy, so it takes stress off of you instead of damaging your body, because damaging your own body, because you have to consider the longevity of your joints and making sure you can live a long, healthy life without pain, limiting your function. Probably the most common reason I see for people coming in with these injuries is a lack of appropriate preparation before exercise or activity. So we mostly take stretching and warm-ups for granted. In our 20s, you could wake up, go run a marathon and go back to bed and not suffer from it. But as you get older, your body's not able to do that. So your muscles are often very tight when we don't use them. The point of stretching and warming up is to loosen the muscles and make them more flexible, because muscles, they contract and shorten, and then they lengthen when we use them. If we try and just go running or play a sport without warming up first, the muscles are hesitant to lengthen. And instead of lengthening and stretching, they will tear. And that can be a common reason why we see those biceps and triceps tendon tears, or even golfers in tennis elbow. And finally, any prophylactic or preventative bracing really are really good to employ now. If you do one of the jobs that I mentioned where you're leaning on your elbows a lot, or if you're sitting at a desk leaning on your elbows to do your work, wearing things like bracing to protect the elbow to make sure you're not repeatedly hitting it, striking it on the ground or the desk, and aggravating the elbow can prevent things like bursitis or even contusions of the elbow if you're at risk of those things. And so that's what I have for today. So thank you everyone for your time and attention. I really hope this was helpful. Hopefully this was able to help anyone in the audience who's suffering from elbow pain identify what their cause is and some treatment strategies you can even employ before coming to the doctor. or even some ways that you could prevent these from occurring in the first place. So thanks for your time and attention. And I'd be happy to take any questions that may be in the chat.
Thank you, Dr. DeBernardis. That was excellent. I actually learned a lot myself here. We do
Hope
have
so,
a few
John.
questions. We do have a few
Go for it.
questions for you. First one is from Darlene. I am soon to be a 60-year-old female in fairly good physical health. I bowl once a week, I lift weights, and I rebound on a celicizer. Recently, my elbow started to hurt. Today, I had a pretty good handshake with a colleague and immediately felt the pain in my elbow. Just wondering what you think the diagnosis might be.
It's a good question. So, it's really hard to make that diagnosis without seeing you and examining you. Like I mentioned, for most of these problems, we don't even need an x-ray, even though we use them to rule out any common problems. But knowing where your pain is, the things that really bother it, that really bother and instigate your pain are really helpful. So my ability to use my hands to feel your elbow and its motion and where it hurts you are definitely the most helpful. I would say most commonly, if I had to roll the dice, it probably ends up being a tennis elbow, especially if it's on the outside, or golfer's elbow on the inside of your elbow are by far the most common. So repeatedly lifting weights, noticing it with a hand shape. So it's actually very common to have tennis or golfer's elbow with not just bending and straightening the elbow, but any gripping activity. So shaking someone's hand, gripping a doorknob, holding something to clean your window, you might find cause your pain. And so when you say I have pain with a really hearty or strong handshake at the elbow, most commonly would probably be tennis or golfer's elbow. But feel free to come in if you need help diagnosing that.
Great, thank you for that. Next question is, in your opinion, what condition is worse, bursitis, tendonitis, or arthritis?
Sure. So it's hard to say because, truthfully, the only thing that matters is how it makes you feel, the pain it causes. So there's all different varying levels of pain from these. So some people, what's interesting is that we diagnose arthritis on x-ray. And so some people on x-ray have really horrifically terrible arthritis and have minimal pain. Some people have very mild arthritis on x-ray, so very early arthritis, but it's causing a lot of pain. So what's interesting is the severity of arthritis doesn't always correlate to the severity of pain. And it's hard for us to figure that out, to figure out exactly why. So I can't necessarily say that bad arthritis is worse than bad tendonitis, because sometimes bad arthritis doesn't even hurt that much. But really, the true answer is whichever is bothering you the most. But I would say, if I had to pick one, probably arthritis, because arthritis out of those three is the only one that's not reversible. Arthritis is when the cartilage in your joints that helps the bones smoothly rub against each other, so they're not rubbing together, that cartilage wears away. And it's one of the few tissues in your body that doesn't regrow or regenerate when it's damaged. So whatever amount of cartilage you're born with, that's what you have for the rest of your life. Arthritis is when it wears away. So over time, just from wear and tear, living your life, being active, the cartilage wears away and you lose more and more. So arthritis is actually progressive. It's something that we know will only get worse over time. It doesn't get better and you can't reverse it. So probably arthritis, because we know that once you start down that road, it continues to get worse. Tendonitis and bursitis can be exceptionally painful. In fact, they could potentially cause more pain than arthritis. However, with rest, anti-inflammatory medications, we can usually pretty effectively reverse the pain. And so I would probably have to say arthritis out of those three.
Great, thank you. Another arthritis question, you might have answered this, but I'll give it to you anyway. Susan asked,
Sure.
How can you tell whether or not your pain is simply arthritis?
Well, it's hard to tell, and that's why we get an x-ray to prove, because there's a lot of times where arthritis pain is very similar to tendonitis pain, similar to bursitis pain, or even breaks and contusions. And so the importance of the x-ray is really to tell, the most important thing to tell whether it is arthritis. If you're asking, how can I at home determine? Well, arthritis, like I mentioned, is kind of like a break in that it makes that smooth road into a more bumpy road. So often we may hear or feel creaking, clicking, catching, popping in our elbow. So it disturbs how smooth the motion of our elbow is. So if you're bending and straightening your elbow and you hear and feel clicking and cracking, it may be because the smoothness of the joint is disturbed. And so that can commonly be seen in arthritis. So that's one hint that you can say, I know this might be arthritis. Arthritis also usually hurts only with motion. So if you also have pain even at rest when you're not doing it, it may not be arthritis. Keep in mind that's a generalization. That's not always true, but those are just two things you could think about when trying to decide or figure out if your pain may be due to arthritis or something else.
Great, thank you. The next question is from Susan again. What are the possible side effects of anti-inflammatory injections?
It's a great question because I think a lot of people say I have pain and they just go pick these medications up from the store and take them without any second thought. But it's something where usually before you consider it, I would recommend talking to your primary care doctor. So we split anti-inflammatory medications up into two groups. Tylenol is one on its own, and then what we call NSAIDs, non-steroidal anti-inflammatory drugs. That includes things like Advil, Aleve, which are ibuprofen and naproxen, things like diclofenac, meloxicam, Celebrex. You may have heard of these. Those all fall under the category of NSAIDs. And so NSAIDs, we try to avoid using in people who have kidney disease because it can decrease your kidney function if you're susceptible to that. If you have any history of heart attack, stroke, or heart disease, because it can affect things like your blood pressure, like how thin your blood is. Also, if you take blood thinners, this can make your blood even more thin. So in people who have these certain diseases or diagnoses already, we try to avoid NSAIDs because it can exacerbate potentially those problems or affect it. Sometimes, depending on how bad those diseases are, it's still safe to take that just under the direction of your primary care doctor. So if you have bad kidney disease or diabetes, heart problems, we try to avoid that. Tylenol is exceptionally safe. Tylenol does not necessarily cause any of those problems. Tylenol is broken down by the liver, whereas NSAIDs are broken down by the kidney. So we only recommend against taking Tylenol if you have a history of liver failure or liver disease, alcoholism that might affect your liver. So those are the times where we say maybe stay away from Tylenol, but typically it's very safe. The only concern I have when I give an NSAID to a patient who has no health history, so no problems at all with their medical history, no other diagnoses, is NSAIDs can affect the lining of your stomach. And so if you take them on an empty stomach, they can cause some irritation or what we call gastritis to the stomach. If you take them a lot and for too long, they can actually result in ulceration or ulcer formation of the stomach. And so you have to be careful about your GI system when you take these too much.
Great, thank you. Next question is, how often is a tricep tear associated with, I don't know if I'm pronouncing this right, olecranon fracture?
Olecranon. Yeah, so I can see the question. So it says, I've seen an abrasion fracture of the olecranon. It did not significantly affect the strength of the triceps. We needed to confirm the cause of pain with an x-ray. So it's incredibly uncommon to see both the triceps tear off the bone and the bone break away from the olecranon break. So usually it's one or the other. Either the triceps tears off the bone or that olecranon, that big chunk of bone, tears off. What you may be referring to is sometimes you can actually get a bone spur coming off the back of the olecranon, and that bone spur is a calcification that occurs within the triceps tendon. So every once in a while, someone may actually tear their triceps and you see a little fleck of bone pull off the back of the elbow. But for the most part, the olecranon is normal or intact. That's actually just a little bone spur or calcification that occurs when the triceps is inflamed. And then if the triceps tears, you can see that little fleck of bone move away from the elbow. That may be what you're referring to, but in general, usually it's one or the other. The triceps tears off the bone, or that large chunk of bone called the olecranon that will break away from the bone with the triceps still attached to it. It's very, very uncommon to see both. In fact, I don't think I've ever seen it.
Great, interesting. Next question: can applying heat be helpful for with tennis elbow? From Janet.
It can, and I would tell you that in general, people say, should I use ice or heat? And I would tell you there's not really specifically a scientific answer to either one. It's really whichever feels better for you. If ice, we generally think of decreasing swelling and decreasing inflammation. Heat, we generally think of using when we have like tightness of muscles and cramping to loosen up muscles, improve blood flow. So they both have their benefits. So honestly, even alternating the two of them can be really, really helpful.
Great. Next question. Please share tennis elbow remedies.
Sure. So really, I would refer you to the slide I had that all those treatment options for it. But really quick, easy at-home things you can try. So going to your local pharmacy and picking up things like Tylenol or Advil or naproxen like Aleve is probably one of the best ways to treat it, because like I mentioned, it's a problem of inflammation. So using anti-inflammatories can be really effective. In general, mostly keeping the wrist still. I know I mentioned the pains at the elbow, but not using the wrist to do things like hyperextend type, to wash your windows, to use a screwdriver, open jars. So really resting and taking anti-inflammatories are by far the most important. Some people have had some success with using, there's a lot of good creams at the pharmacy, like diclofenac or Voltaren cream and gel that you can rub, like an ointment you can rub over the elbow where it hurts, that oozes in or helps you absorb some anti-inflammatories. And those can be really effective too. So all things you can try, but mostly it's giving the tendon some time to relax and to breathe before getting back into whatever activity you're doing that causes your pain.
Great, thank you. Next question. Do you find clients that have elbow problems have more proximal issues as well, shoulder and neck?
Yeah, another excellent question. And you sound like someone who may be familiar with this either in your own life or maybe you work in the medical field, but it's a good question because tendonitis commonly occurs not just by itself, but in twos and threes. And so, I will tell you a lot of people come in with shoulder and elbow tendonitis at the same time. And it usually ends up being either the activity they're doing that is inflammatory to their arm is affecting both their shoulder and their elbow, or one problem starts and you compensate by extra motion at the other joint, and then it results in that pain. So for example, I often see people who started with pain over the outside of their shoulder, and you get an MRI and it shows that they have rotator cuff tendonitis. So tendonitis of the tendons around the shoulder that let you lift your arm, rotate your arm in and out. And because they have pain and they want to move their shoulder less, they start compensating for that by moving their elbow more. So now you're using your elbow much more than you did prior to your shoulder pain, and results in overuse inflammation of the elbow. So it's absolutely very common to get shoulder and elbow tendonitis together because when one hurts, you start using the other one more. In general, the neck ends up being its own issue. So it's not uncommon to have pain over the outside of the forearm that radiates down the arm, even to the hand. Sometimes you may have numbness and tingling too. And that pain on the outside of the elbow is not actually coming from the elbow, but from a pinched nerve in the neck, which happens for a number of different reasons. That's a whole extra hour-long talk in itself. But you can absolutely see shoulder and elbow pain occurring together. And sometimes it may actually be that the shoulder or the neck and the elbow pain maybe are two completely different problems, not even connected. They're just happening at the same time. So absolutely.
Thank you. Thank you, Darlene. We're happy that you found this lecture very helpful. Next question, Dan. I was previously diagnosed with tennis elbow. PT helped a bit. Any thoughts on helpfulness of acupuncture?
Yeah, that's a good question. And I appreciate you bringing it up because I actually didn't mention that in tonight's discussion. And so I would say acupuncture can be absolutely very helpful. You may be familiar, but the point of acupuncture is that inserting fine needles around the elbow, it can help stimulate blood flow. Blood equals healing. Blood has all of the healing components that your body has to offer. And so if we can increase the blood flow to the part of your elbow that's inflamed and painful, the thought is that that can generate more of a healing response, and that can result in a better response as far as decreasing your pain. And so I think if you want to try acupuncture, you absolutely should. I think the reason you may find some doctors don't recommend it is not because it doesn't work, but because we don't often have physicians in our office who can perform that. And so if you want to pursue that, I think it's absolutely a good idea. Interestingly, in our Manhattan office, we actually do have a physician who does acupuncture and dry needling. And I think some of these alternative techniques can be really, really helpful at resolving your pain when things like therapy, anti-inflammatories aren't working. And I think it's a good idea to try it.
Okay, thank you. Next question. Hi, I am an occupational therapist currently treating a patient with terrible triad injuries 5 weeks post-op. We are currently doing some active assistant range of motion in supine. Do you typically advise to refrain from, I guess I don't know what the acronym, AROM?
Active range of motion.
Okay.
Yeah, so she's saying, do you advise to refrain from active range of motion supination in the supine position until 6 weeks? That was what was advised on his protocol. So I would say, yeah, that sounds totally reasonable. So she's a well-educated occupational therapist, obviously, so she's using some lingo that may not be apparent to everyone in the chat. And so to define that for everyone, a terrible triad injury is when you have an elbow dislocation and a couple of the bones in the elbow break, both the ulna and the radius, and the elbow dislocates. So there's ligamentous damage too. And this is a really devastating injury that almost always needs surgery to fix it. And so the question is, the patient's about 5 weeks after surgery, they're doing active assisted range of motion. So passive range of motion is when, if you're the patient, you're not moving the elbow under your own power. your therapist or someone else is moving it forward. So you're not putting in any effort, they're moving it for you. Active range of motion is when you're moving the elbow all by yourself, no one's helping you. And then in between is what we call active assisted motion. And so active assisted is when you are moving the elbow, but with the help of someone else, your therapist or whoever is helping you with the motion. And so 5 weeks out, we're doing active assisted range of motion in supine. Supine means laying down on your back. And you usually start motion like that because it eliminates gravity. And so you can move the elbow without any extra resistance. And so the question is, do you refrain from active range of motion in supine until 6 weeks? And I do, because like I mentioned, it usually takes at least 6 weeks to see enough healing on x-ray that you know, okay, healing is starting to occur. And so my body is trying to bridge this fracture with bone. And when you see that on x-ray, you know that enough healing has happened that you can start moving the arm under your own power, as long as you're not using resistance. So I think active range of motion in the supine position at 6 weeks, waiting till 6 weeks is totally reasonable. I would get an x-ray. Once the x-ray shows me that some healing is going on, that's when I would say, okay, start beginning active range of motion. So have the patient themselves start to move under their own power. Again, in supine is good because it eliminates gravity. So very gentle range of motion with no resistance yet, just active range of motion. So I do think that's totally reasonable.
Great, thank you. Next question. With a diagnosis of arthritis or tendonitis, is it okay to lift light weights?
So I would say it is, but usually in my office, I recommend modifying your technique and how you do it. So for example, if you have tennis elbow, that's pain on the back of your elbow. So lifting weights with your palm down puts a lot of stress on it, or sometimes palm up puts a lot of stress in golfer's elbow. So I recommend you can lift weights, but you do it with your wrist in a neutral position. Neutral position is like the position your wrist is in if you go to shake someone's hand. Your thumb is facing up toward the ceiling and your pinky is facing down toward the ground. So in that neutral position, you're not putting extra force on the wrist extensors or the wrist flexors. You're putting a little bit of force on both. So in a neutral position, it can be really helpful. And so light weights are also better too. Obviously, heavy weights put a lot more stress on the wrist and the elbow and the muscles. And so, I tell people, you want to stay active and you want to lift weights, but it could be contributing to your pain. So instead of trying to lift heavier weights for low reps, switch. Do lighter weights for higher reps. You get an equally good workout, but maybe a little less stress on the elbow. So it is okay, with the caveat that you're modifying how you do it to accommodate your pain.
Great, thank you for that. Next question. Do you have specific criteria for return to powerlifting after a tricep repair?
I do. So like I mentioned, in your average person, return to general activity, usually without restriction, 6 months. Powerlifters are difficult because they're usually itching to get back into the gym and train. They're very unhappy with the loss of muscle mass that happens with resting. And so my criteria are full unassisted active range of motion. So they have to be able to move their elbow in flexion, extension, pronation, supination, every direction completely without any limitation and pain-free. And they have to, I have them set up for what's called a progressive return to lifting protocol. So they start with general, what are called compound exercises, and they start with open chain and progress to closed chain. And so open chain is any exercise where your hand is free in space, whereas closed chain is where it's either locked into a bar or locked into the ground. So for powerlifters, I have them start back no sooner than 6 months. And depending on their progress, maybe even later, once I feel that their strength is returned, I have them start with open chain exercises. So that's like free weights. So your hand is free to move in space. Once they feel comfortable doing that pain-free, I let them to progress to closed chain exercises. So things like a single bar, chest press, deadlifting, and things like that, push-ups, planks, things like that, where their hand is locked and can't move in space. Once they can do that without pain, then they can go back to powerlifting. And usually, if they're just starting at 6 months, it takes them about another 3 months or so to get where they want to be as far as their goals. So they're probably not doing things like competing or lifting their full, max weight or hitting PRs until at least 9 months.
Great, thank you. Next question. Can using anti-inflammatories mask how bad your condition is and lead to more overuse?
I think that's a really appropriate question, because a lot of patients will come into my office and say, I'm having this really, really terrible pain, and it's bothering me when I do this. And I'll say, well, are you taking any medication for the pain? And they say, no. I don't like to take medicine, or I'm worried if I mask the pain, I'll damage it more. So this is a very commonly asked question in my clinic. And I would say it's absolutely okay to take because it's part of the treatment. A lot of people say, oh, it's just masking the pain. But keep in mind, a lot of these overuse injuries, like I mentioned, it's a problem of inflammation of these tendons. And so taking anti-inflammatories are not just masking your pain, but treating the problem. But the other thing I recommend is I don't often tell people take anti-inflammatories and do everything you've been doing, right? Because if you do that, then you continue the overuse activity and you're continuously generating this problem. You continue to generate pain and the inciting activities that cause inflammation. And so if you can, I never recommend just anti-inflammatories. I also recommend lifestyle modifications and ergonomic changes. So changing the equipment you're using, changing the level of your activity, changing the severity or the intensity of your activity, your technique, things like that. So you have to actually make lifestyle changes to prevent these conditions from coming back. So I would say, I tell patients, don't be shy to take these medicines. They're not just covering up your pain, they're also treating the problem depending on what it is, right? If it's a tendonitis, then absolutely. But you have to actually make the lifestyle changes that will prevent it from flaring up again, because it can easily happen if you don't. Before we move on to the next question, I just wanted to, because I see some people have logged off, I'm going to stop sharing my screen, and I'm going to have Rachel here share her screen. She's just going to give you my information. If you have any questions, want to call the office, telling you where I practice and how to contact us. So we'll keep answering the last few questions, but I'm just going to do that before more people log off. So you guys can see these are just the two offices that I typically practice at, both in Manhattan and Jersey City, and numbers you can call to make an appointment. But go ahead with the next question, John.
Sure. Susan asks, what if the pain is sporadic rather than constant?
Then it becomes probably more difficult to treat, right? You'll say, some days I feel great and some days I don't. I think a lot of chronic or long-term problems can happen like that. You'll find if you have arthritis or tendonitis, like some days it's really bothering me. It wakes me up from sleep. I can't do something simple like lift my coffee cup to drink it. Some days you'll feel great. You may find with things like even arthritis, the weather really impacts it. So really bad, rainy, snowy, cold days, you'll be like, man, this really is aching and it's really bothering me. And with great weather, it gets better. And so the question is, what do I do when it is bothering me? Because if it's not, there's not much to do. But when it is bothering me, that's why we usually recommend things like anti-inflammatories on an as-needed basis. We don't often say, hey, take Tylenol, take Aleve, take ibuprofen every day like it's an antibiotic for months. It's on an as-needed basis, meaning when it's bothering you, you take it. But I would also encourage you, if it's sporadic, to pay attention to the things that cause it. So on days when it's bothering you, what's different? Did you have a really intense workout the day before? Is the weather really bad today? Are you doing something new at your job you haven't done before, and all of a sudden it's bothering you? The days when it's feeling good, what's different about that day? Did you have a rest from the gym? Are you working from home that day? And so you notice, hey, the activities I usually do at work, I'm not doing today. It's actually feeling good. So I think the only benefit of sporadic pain is it can really help you determine what are the things that flare up this pain? What are the things that make it hurt more? So you can better identify what the problem is and try to avoid it. But it is difficult when it's sporadic, because sometimes it's even difficult to pinpoint those instigating factors that cause your pain. And so really treat it on an as needed basis, but it can give you some good information.
Great, thank you. And finally, our last question is, what are your thoughts about acupuncture? I had a serious fracture 2 years ago with reduced range of motion.
Yeah, so I never recommend against acupuncture because you don't lose anything by trying it. Acupuncture doesn't result in any long-term soft tissue damage. It doesn't change much about the elbow. Like I mentioned, its purpose is to promote and stimulate blood flow to help with healing. I'd say it's, if I had to make an educated guess, it may be less effective in someone who has stiffness or reduced range of motion because of a fracture. That's because that's now a combination of a bone and a soft tissue problem. So when we have a break of our bone, it's painful and we move our tissue, our elbow less, and that causes stiffness. When over a long period of time, so for example, 2 years, our elbow is not moving much, the soft tissues that are usually flexible around the elbow start to contract and become stiff. So now the bone caused the problem originally, and the soft tissues become tight. That's a secondary problem. And so acupuncture can help the soft tissue component for sure. It's possible to stimulate blood flow and help with healing and help loosen up the muscles. So I would absolutely recommend giving it a shot because, like I said, you lose nothing by trying it. But it may not help any stiffness that's arising from the joint if it was disrupted after a break. And so sometimes you need something a little bit more aggressive than acupuncture, like some really good physical therapy with someone who's going to really push the elbow and encourage you to move it more.
Great. And I spoke too soon. I have one other question here. Would you recommend
It's
deep
okay.
massage for the forearm with tennis elbow?
Yeah, I actually think of deep massage even similar to acupuncture, in that really massaging the muscles, it loosens them up and it helps them become more flexible, but it also stimulates good blood flow. And it's another thing where I say you lose nothing by trying it. And I've absolutely had patients that come into my office and say, I tried these medicines, doesn't do anything. Therapy was great, but I feel like I've sort of plateaued. Like I got better to a point, I'm just not getting better. And they've said, but you know what? I actually tried this deep tissue massage, and it was really helpful. I feel really great. The pain comes back, but I go for another massage every week, every couple of weeks, and it feels really great when I do it. And so, what's interesting about tennis elbow is that it usually hurts to palpation or to press. So you may actually find it uncomfortable to a degree, but sometimes massages like that can incite some pain, you end up feeling pretty good after. So I would tell you, beware when you get the massage, it may be pretty tender, but if it does help you feel better afterward, I think it's a great idea.
Great, thank you. And thank you, everyone. Really appreciate all your participation, a lot of questions tonight, and a great presentation by Dr. DeBernardis. For more information, or if you would like to make an appointment with one of our physicians in the future, you can visit us online at rothmanny.com, or you can call 888-636-7840. And just a reminder, we will be sending out this recording to all registrants within the next week or so. So please be on the lookout for that email as well. And again, thank you all for joining us tonight. I know we went a little bit over, but I think it was well worth it. And thank you, Dr. DeBernardis, for your time.
Yeah, I appreciate everyone being so interactive. I'm happy everyone had so many questions. These talks are much more beneficial when you guys are really engaged like this. So thanks for your attention, and I hope to see you in the future.
Great. Good night, everyone.
Good night.